Hello, my name is Ari Javidan, and I'm the Program Coordinator for the National Consortium of Telehealth Resource Centers. Welcome to the latest presentation in the NCTRC webinar series, Telehealth Policy Update, What Has Happened and What to Look For in 2022. Today's webinar is hosted by the Center for Connected Health Policy. These webinars are designed to provide timely information and demonstrations to support and guide the development of your telehealth programs. These webinars are presented on the third Thursday of each month. Next slide, please. To provide some background on the NCTRC, located throughout the country and funded through a cooperative agreement from the Office for the Advancement of Telehealth, there are 12 regional telehealth resource centers and 2 national, one focused on telehealth policy and the other on telehealth technology. Each serve as focal points for advancing the effective use of telehealth and supporting access to telehealth services in rural and underserved communities. Next slide, please. A few tips before we get started. Your audio has been muted. Please use the Q&A function of the Zoom platform to ask questions. Questions will be answered at the end of the presentation. Please note that closed captioning is available for today's webinar and is located at the bottom of your screen. Today's webinar is being recorded, and you will be able to access today's and past webinars on the NCTRC YouTube channel. And with that, I will pass it on to our presenter today, Mei Kwong, Executive Director for the Center for Connected Health Policy.
Thank you, Aria, and thank you everyone for joining us here today. As Aria mentioned, my name is Mei Kwong, the Executive Director at the Center for Connected Health Policy, which is the National Telehealth Policy Resource Center. And today we're going to be talking about the Medicare 2022 changes, as well as an update on some of federal issues and also some state issues as well. Few disclaimers before we get started. Please know that any information provided in today's talk is not to be regarded as legal advice. It is strictly for informational purposes. CCHP always recommends that if you are interested in a formal legal opinion, please seek out legal counsel. And also know if I happen to mention a company or show a picture of a product or something, know that neither I nor CCHP has any type of relevant financial interest, arrangement, affiliation, or relationship with such an organization. A bit of background about CCHP. We were established in 2009 as a program underneath the Public Health Institute, actually to be a California telehealth policy organization. However, an opportunity to become the federally designated National Telehealth Policy Resource Center became available in 2012 through a grant from HRSA. CCHP applied for that. We received it, and we've been serving in that capacity ever since. CCHP also works with a variety of other funders and partners on the state and federal level on other telehealth projects or connected health projects. We act as the administrator for the National Consortium of Telehealth Resource Center, which, as Aria said, is made up of the 14 Telehealth Resource Center underneath the same HRSA program as CCHP. And CCHP also acts for a group in California called the California Telehealth Policy Coalition. We founded that group. It includes over 160 statewide and national organizations who are interested in advancing telehealth policy in the state. So right now, as most of you know, we are in the second year of our pandemic. And when the pandemic first began, there were a flurry of telehealth policy changes, both on the federal and state levels. They were, for the most part, temporary changes. But as you can see from sort of this, 100,000-foot level overview here, there were a lot of common areas or common issue areas that the federal and state policy changes touched upon, such as location of the patient, the types of services that are allowed to be provided via telehealth that would get reimbursed by either Medicare or Medicaid, the modality that was used. And then there were certain issues that were exclusively more on the federal side to handle and more on the state side to handle. So for example, on the state side, they had control over licensing issues, but on the federal side, they had control over prescribing of controlled substances. But as you can see, there's like a lot of commonality still, at least on the particular areas that they focused in on. And these are the areas that had those temporary telehealth policy changes and the areas that a lot of people are wondering, what's going to happen once the pandemic is over. So what we do know now is that in some jurisdictions, some states, they've made some permanent changes, but for the most part, really the landscape out there, definitely on the federal level, a lot of it is still unknown because we're still underneath the public health emergency. So we're going to tackle the federal level first. And really, this is going to be like the bulk of sort of this presentation, just because I can't cover all 50 states. So I'm just doing sort of more of a general overview of what's going on in the states. So this will be focused mainly more on what's going on with Medicare, because when you talk about federal telehealth policy, a lot of that is really centered around Medicare. Yes, there are other areas that federal telehealth or federal policy touches upon telehealth, but the bulk of the existing telehealth specific policy is in the Medicare program. And to understand the Medicare policy around telehealth or related to telehealth or technology delivering services, you have to understand that Medicare has two different approaches to those services. There's the telehealth approach, and then there's the communications technology-based services approach. Now, what's the difference? So when you're talking about telehealth policy underneath Medicare, that is the policy that probably a lot of people are familiar with because it's embedded in federal law and it's been around for a while. So it's the policy that says, oh, it needs to take place in a certain geographical location. It needs to be taking place in a certain type of facility, such as a doctor's office or a hospital or clinic. You can only really use live video for the most part, unless you're using, unless you're in a demonstration program in Alaska and Hawaii, then you can use store and forward. That's the telehealth policy in Medicare's eyes. It's embedded, a lot of it's embedded in federal law. It's very restrictive. Communications technology-based services policy underneath Medicare, it utilizes telehealth technologies to deliver services, but it's not considered telehealth in CMS's eyes. Now, why is that? How do they distinguish the difference? So kind of like the easiest way probably to explain that is that telehealth is a one-to-one replacement for an in-person service. I go in and I see my primary care provider. I can do that in person or I can do that via telehealth. There's like an actual replacement for it taking in place in person that it can now be done via telehealth. Communications technology-based services are services that technology now enabled us to be able to do for the patient, but didn't necessarily take place in person. So for example, your remote patient monitoring a patient with hypertension and you want to have their blood pressure readings for a week. I'm not going into like my primary care doctor's office every day for, let's say, 3 times a day to have my blood pressure reading done. But now technology allows me to do that through a device at home and send that information electronically into my primary care provider. So those types of things where there's not that one-to-one replacement, CMS is considering those communications technology-based services. They're services that we think are pretty good. We want to pay for them, but they don't necessarily have something as an equivalent as in person. So we're not going to consider that telehealth. It's this other category. Why I'm spending so much time on this is that during the pandemic, I think this got a little confused for some folks, especially if they were newer to telehealth. And so they were wondering why some of their reimbursement rates were different. It was simply because they were billing something that was a communication technology-based services as opposed to a telehealth service. Now, this is a CMS policy that I'm like spending time on and talking about. Once you start going down to the state level, it gets really confusing because some states treated some of the communications technology-based services as underneath their telehealth policies. Others kept it separate and others just kind of, didn't really reimburse for them. So it's all different on the state level, but where Medicare is concerned, it's these very distinct buckets out here. There's the telehealth policy and there's communications technology-based services. Communications technology-based services, because they're not considered telehealth services in CMS's eyes, they also don't have those telehealth restrictions, such as you need to take place in this type of geographic area. They can only be in these types of locations. They have their own limitations and policies that CMS created, but they don't necessarily face the limitations that they see, that telehealth sees that are in statute. Now, also to understand telehealth policy in general, and definitely what's going on with Medicare, is that there's usually 4 issue areas or elements that the telehealth policy touches upon. It touches upon service, location, provider, and modality. So you might have a policy that says this Medicaid program will reimburse for mental health services. So the services that will be reimbursed when the patient's located in a doctor or a clinic setting, the location of the patient, when it's being provided via live video, the modality that's used, and when it's being provided by a psychiatrist, the provider who's allowed to provide that service and get reimbursed. So those are the 4 basic areas that a lot of the telehealth reimbursement policies touch upon. And that's where you'll see like where the changes impact the service, location, provider, and modality. Now, the thing is, when you're talking about Medicare and CMS, 3 of these areas CMS doesn't really have a lot of control over as far as setting the policy because it's embedded in federal law. So they're very limited in what they can do. Service is really the only area that they have a lot of control over, what services are going to get reimbursed. But location, the type of provider who can be reimbursed, and the modality used is like a little, they have their hands a bit more tied in that. That's like really embedded in federal law. Although the modality one, we'll talk about that in a second, they did find a creative way as to like addressing that a little bit without having to have like a congressional change done. So what happened in 2021 that's going to impact 2022? So for those who are not familiar with it, what CMS does every year for the Medicare program is they have a physician fee schedule that basically lays out like new policies that they would like to propose and institute for the following year. So for 2022, they introduced their draft proposals sometime in the summer, usually around July of 2021. They give you like a 60-day period where the public can comment on it, and then they finalize it usually around in November. Sometimes they're as late as December, but this time they did in November, of saying like, this is going to be our final policy. This is what's going to go into effect unless otherwise stated on January 1st of the following year. So that's what happened in 2021 for the policies that are going to take place in 2022. It came out in July. It was finalized in November, and those are the links where you can like see all that. But basically, I'm going to be covering like all the things related to telehealth. So what was the first thing that happened? Well, the first thing that we're going to cover are basically the services that are covered. So this is, as I said earlier, the one area where CMS does have like a lot of control over what they'll say, so they don't have to wait for Congress in order to allow them to act. So every year, what CMS does is that they allow the public an opportunity of suggesting services, CPT codes, that can be put on the permanent telehealth list. And then they judge those, they decide like, whether to approve it or not based on two tests. You can pass one or two tests in order to get on the permanent telehealth eligible services list. And those two tests are called category 1 test or a category 2 test. And category 1 test is basically saying like, well, if the service that's being proposed to be put on the permanent list is very similar to a service that's already on that list, it passes the test. The category 2 test is, well, if you provide us with enough evidence to support that this can be done effectively over telehealth with good benefits, then we'll move it over onto the permanent list. Category 2 test is really hard to like pass. So usually what you see like services getting put on the permanent list is because they passed category 1, very similar to stuff that they're already reimbursing for. The previous year in 2020, CMS created a category 3 list. Now, what category 3 is a temporary holding bucket. So when the pandemic started, CMS added a bunch of services temporarily to the telehealth list and said, these services during the pandemic, you can provide via telehealth and we'll pay for it. But this is a temporary list, so they're not on your permanent telehealth list. Since that time, they've added a couple services to the permanent list, but what they did was in 2020 for 2021, they created a category 3 where they said, we're going to take a chunk of those temporary services on the COVID list and put them in category 3. And what that means is that they're going to hang around a little bit longer after the pandemic is over. So the way they had it phrased previously was that in category 3, those services will stick around until the end of the year that the public health emergency is declared over. Well, they changed that last year. And what they're now saying is they've given it a more definite deadline. They're saying like, these temporary services in category 3 are going to stick around until the end of 2023. So basically that time is they feel that'll give them sufficient time to kind of examine the evidence on whether, they pass a category 1 or a category 2 test, and then they can be moved over to permanent list. So let's say, for example, that the public health emergency is declared over this year in 2022. These services in category 3 that they put on there will hang around until the end of 2023. However, if any of those temporary COVID services, any of those services on that list, which are not currently on the permanent list or in category 3, then they will disappear when the public health emergency is declared over. So just be clear on that. Category 3 is a temporary holding bucket until the end of 2023, so they can decide whether they're going to move it on a permanent list. If you're not on the permanent list already as a service, or you're not in the category 3 bucket, then once the public health emergency is declared over and you're on that temporary COVID services list, it goes away. It's no longer going to be eligible once the public health emergency is declared over. They also, for 2022, they did add some of those temporary COVID codes over to, no, I'm sorry, what they added like more of the category 3 codes. So they had certain codes that they did for 2021 in category 3, and they added a couple of additional codes for that temporary bucket in category 3. So just to be clear, you've got 3 buckets. You've got your permanent telehealth list that stays there no matter what's going on, whether, you know, the public health emergency is over, it's still there. Those are still eligible codes. You got category 3, some codes that are going to stick around until the end of 2023. And then you have your COVID telehealth list that has some codes that will disappear once the public health emergency is declared over, unless some new change happens since then. All right. Other changes that they made. Now, this one, again, is not by CMS's choice. This was actually a piece of legislation that passed in December of 2020, the Consolidated Appropriations Act, that had a bit of telehealth policy in there. So basically what CMS was doing was simply like implementing what was in statute then. And what this was it expanded the use of telehealth to provide mental health visits. So what the Consolidated Appropriation Act said, you can use telehealth to provide mental health visits without the geographic limitation coming into play, and also can be provided in the home. However, and this was not, again, not CMS's choice, this is what was written into the bill. They said, however, there needs to be an in-person visit with that telehealth provider at least 6 months prior to before telehealth services are being provided, or services via telehealth are being provided. So what CMS did is just simply implement that policy. So to do that, they said the same thing. They were saying that, okay, you can use telehealth to provide mental health services, and the geographic limitation would not apply, and you can do it in the home. However, you do need that 6-month visit to take place. And what they also said was, additionally, if the 12 months in, like, you need to basically like have that in-person visit renew every 12 months. So to start your telehealth services, you need to have had an in-person visit with the telehealth provider at least 6 months prior. And then you need to like basically have at least one more in-person visit every 12 months, basically, just to like keep that engagement there. They also allowed audio only to provide the mental health visits, and they also redefined what an FQHC mental health visit was. So we'll get into like a little bit more details on each of these bullet points here. So mental health visit, again, I said it was in the Consolidated Appropriation Act. What they did say is that you need to have that 6-month in-person visit before the telehealth services take place, and subsequently every 12 months. They did allow some limited exceptions to like the 12-month sort of requirement. Basically, they said if it would really disrupt services or wouldn't benefit the patient, then we'll kind of let that slide. They also said that what the in-person visit means is that you need to have had some sort of service rendered to the patient in person, and it needed to be paid by Medicare. Probably like a tracking thing for them, and that it's like, okay, you actually did have an in-person visit, you just didn't sort of like see somebody really briefly and you count it as your in-person visit. They say it needed to be paid for Medicare in order to count. They did say, though, that if you couldn't do it, but there was somebody who is underneath the same subspecialty in the same group as you, they could have done that in-person visit for you, and that can count. Now, and this is where we start getting into like vagueness on like, well, what does this mean exactly? So far, CMS hasn't issued anything clarifying that I've seen, but basically what they said, at least in their physician fee schedule, is that for home, they're going to have a wider definition for what the home means. It could also include temporary lodging, and this was to, you know, basically accommodate folks who may be homeless or maybe were displaced at a period of time, or if they were traveling. And also, if you needed to travel a short distance from your home, it would still count as being an eligible site. And that was probably to accommodate folks who maybe didn't have connectivity within their home and maybe needed to travel to somewhere where they could get Wi-Fi. And then, as I mentioned earlier, they said the in-person visit requirement doesn't really need to happen or doesn't apply if the provider and patient feel that it's going to like interfere with the benefits of like receiving services for the patient, or the patient receiving services or their care. Again, it's very vague. I don't know like how you would capture that in like the record to like prove that that was going on and that's why the decision was made, or like, you know, where are the cutoff lines on there. I've been hoping to see if there would be more sort of like clarifying information from CMS to be issued, and there hasn't as of today. There has not been, but this is what it said, at least in the physician fee schedule, the final physician fee schedule. So you have these kind of like nuanced exceptions to the policy, but basically the policy is that you can use telehealth to provide mental health visits, and the geographic limitation doesn't apply. You can do it at home, but you need to have an in-person visit 6 months, and then you need to have another one every 12 months. There are some nuances and exceptions here, and these are those nuances and exceptions. Audio only. So this is one area where I said that it's mainly in statute, but CMS found a way to like have a little bit of flexibility here. And basically what CMS did is that they allowed audio only to be used as a modality to provide mental health services. And the way they did this is underneath federal law in that telehealth section, it simply says that telehealth is services are being delivered via a telecommunication system. And it's not defined in federal law what telecommunication system means. So that is left up to CMS to kind of define that. And the way they've defined it is live video, and they added in audio only can be used if you're talking about mental health services. So this does not mean you can use audio only to provide other types of services, let's say for, you know, dermatology or cardiology or anything like that. It is only for mental health services if you're talking about getting reimbursement from the Medicare program. So audio only can be used to provide mental health services if certain conditions are met. And that is that it is for an established patient. The patient is at home. The provider has the capability of doing live video, and the patient can't or does not want to do live video. And that's, you know, maybe they don't have, again, maybe they don't have like good connectivity, so they have to do it by phone. And then we see again that 6-month prior visit, in-person visit, and 12-month subsequent visit requirement in there as well too. So you're allowed to use audio only, but you need to like meet these certain conditions. Plus you have that 6-month, 12-month in-person visit as well. That's required of this as well too. FQHCs and RHCs. Now, this has been a little bit interesting. As most of you know, FQHCs and RHCs were allowed temporarily to be telehealth providers during the pandemic. However, they are not on the permanent telehealth provider list for Medicare. So that would require a statutory change. So you're asking like, well, how were they able now to provide services via telehealth? You're an FQHC and RHC. That is because CMS redefined what a mental health visit means for an FQHC and RHC. So there's a specific definition for a visit for these organizations, and also a specific definition for what a mental health visit is. So CMS just changed the definition of it to also include encounters furnished through interactive real-time telecommunications technology. So what that means is FQHCs and RHCs can provide these mental health services via live video and audio only. But because they redefined it as the mental health visit, they did a redefinition of the mental health visit, it doesn't mean they're providing it via telehealth. It is just a mental health visit for them. So what that also means is FQHCs and RHCs in this situation are not going to face those telehealth restrictions because they're not providing telehealth. They're just providing mental health visits. They have all those other requirements that they face when providing a mental health visit that are going to apply in this situation, but those telehealth limitations don't necessarily apply to them. So they will get like the regular rates, but they are going to have to do the 6-month in-person, 12-month in-person subsequent visit if the patient is receiving services in the home. So there's other conditions attached to it, but as far as like those telehealth limitations, they're not attached to the FQHC and RHC because they're not providing telehealth. They're providing a mental health visit. So sort of like earlier when I was talking about those communications technology-based services, it's like labeling it something else so it doesn't usually face those telehealth requirements. This is what's happened here. It's like mental health visit, its definition was expanded, so it's not facing those telehealth limitations. It's facing other limitations, such as requiring the 6-month, 12-month subsequent in-person visit and what other what other sort of like requirements that you have to meet, FQHCs and RHCs have to meet when providing mental health visits, but those telehealth limitations don't necessarily apply. RHCs and FQHCs can provide services over audio only. Now, again, it's sort of like, well, I've had already questions of like, so how do we record this? I mean, how do we track it or record that we did it this way? No clarification yet. I did see that today that CMS issued a Medicare Learning Network booklet for RHCs that had a section on this. It just basically said what I just told you, but I provided the link in case you wanted to go see it, but there's really not sort of like more clarifying information on how you record it. So I apologize for that. We're all still waiting for CMS to come out with like sort of more explicit directions and instructions on this, but that's the best that I have, the most information I have right now. Now we're going to get into, that was all the telehealth stuff, and it was a lot. It's complicated. I know it's probably going to take people a little bit of while to like get used to it. But right now we're going to move over into the communications technology-based services. Now, communications technology-based services is sort of a little bit of your catch-all here in Medicare. That's actually where a lot of your remote patient monitoring stuff is. And they have them in clusters of like different sort of areas. So they have chronic care management there. And then they create a new category for 2022, remote therapeutic monitoring. And these are the codes and the definitions for what they have set up for there. So my slides are available after the session, so you can look at that. I'm not going to go over all these things. The next couple of slides are pretty text dense heavy, so I'm not going to like really spend a lot of time on them. You can look at those later. These are a couple other changes that they made related to connected health or telehealth during the physician fee schedule. So there was a permanent adoption of the virtual check-in, which was a longer check-in. Previously, you had a virtual check-in that was like just 5 to 10 minutes. They made a longer version. It's G2252. So they made permanent adoption of that. So that's sticking around. That's sticking around even if the public health emergency is declared over. And then they did a couple of MER codes for chronic care management and principal care management. They've added those as well too. And then a couple of other sort of policy changes that are out there. Again, I'm not going to spend a lot of time on this. You can take a look at the slides later, or CCHP has a fact sheet related to physician fee schedule. You can also look at that. But some of the other changes that they made was there was an increase in originating site facility fee. It was up to $27.59 now. They also during the PHG, CMS is allowing for certain in-person supervision requirements, availability of supervised in-person be provided virtually through telehealth. They were asking like, should we make this permanent? And they decided that, they're not going to quite make a decision yet. They're still going to like kind of examine that issue. So those were a couple other things that were in the physician fee schedule. So key points to remember. All that 6-month in-person visit that I was talking about, that's permanent telehealth policy. So what that means is it does not go into effect right now because we're still underneath the public health emergency. So if you're worried about, oh my gosh, I need to go do the 6-month in-person visit. No, it doesn't kick in yet because we're still underneath the public health emergency. So we're still operating under those broader telehealth policies. Once the public health emergency is declared over, yes, that's when it'll kick in. You got to worry about it. So it is good right now to start thinking about it on like what's going to happen. How are you going to like work with this once the public health emergency is declared over? But because we are in a public health emergency right now, CMS is not requiring those. And that may also be why they've been a little bit slow, I think, in like having more explicit policy out, is because we are still underneath the public health emergency. So just for those who don't know, the public health emergency was renewed on January 16th for another 90 days. So we have like, unless they declare it over early or something like that, we have like at least another 90 days before these policies kick into gear here. Want to reemphasize that the changes that allow FQHCs and RHCs to provide mental health visits via live video and audio only, it's not considered telehealth. So FQHCs and RHCs are not suddenly made telehealth providers. So they're not suddenly able to provide all these other services via telehealth. It has been a redefinition of what a mental health visit is that allows them to use these modalities. So keep that in mind that that is not telehealth. Technically, it's not scored as telehealth for them. It's not called telehealth. They're just providing a mental health visit through these modalities. Additionally, once the public health emergency is declared over and this kicks in, at FQHCs, transition over to this, and they have that 6-month, 12 months in-person requirement and everything. They're saying like, when do we need to do it? It only applies for FQHCs and RHCs to do that when the patient's receiving services in the home. So if the patient comes into your clinic and they receive services from the provider, telehealth provider, while they're in your clinic, you don't need to have that 6 months in person, 12 months in person element met, because they're not at home, they're in your clinic. So it's only when they're receiving services in the home that 6 month in-person visit, 12-month or reoccurring visit like kicks in. So keep that in mind as well too. But again, because we are right now underneath the public health emergency, all this 6 month, 12-month in-person visit thing stuff, all those requirements, it's not activated right now. That also probably means that CMS is probably going to take a little bit longer as like having more explicit policy. But right now we don't have to, you don't have to put that into place because we are underneath the public health emergency. Federal legislation. I'm not going to spend a lot of time out there because there's a lot of federal bills out there. We're currently tracking over 100 pieces of federal legislation that's related to telehealth. A lot of them are talking about making some of the temporary changes permanent, or they're talking about COVID in some way. There's a lot of interest around licensure and mental health and pilots related to telehealth in these pieces of legislation. I get asked a lot on, well, are any of these going to pass? I would say like an individual telehealth bill, probably not. But what has happened historically is that a lot elements from these bills have been plucked out of them and put into larger bills. And that's probably, there's a likelihood of that happening. If there's like a larger bill to pass, you might see some telehealth stuff in there because they've taken them from some of these telehealth bills and just passed them underneath the larger bill. But I don't give like high odds for a telehealth specific bill of passing, at least on the federal level. Other federal things to be aware of. So always a big issue is the F word in telehealth, and that's fraud, and concerns about that. So last year, the Office of the Inspector General that really looks at fraud on the federal level in the Medicare program is basically saying that what they found, at least so far, was not necessarily telehealth fraud. So it's not people saying like, I did telehealth services and they're billing for those telehealth services. It wasn't necessarily those things that were happening. It was more telemarketing fraud of saying like, oh, I ordered durable medical equipment through a telehealth service and the patient didn't need that durable medical equipment. So it's more things like that rather than actual telehealth fraud. Now, they also did say that we have not really delved into, at least at that point, or that they were willing to share like COVID cases with telehealth taking place during COVID. So that may change coming, over the next couple of months or a year or two from now or something like that. But at this time, this is what the Office of the Inspector General has said. They also do have 2 reports that are coming out this year to be aware of Medicare telehealth services during COVID-19 and program integrity risk, and also use of Medicare telehealth services during COVID-19. They said those will be released this year. So that may, again, like change things a little bit as far as like their statements. But up to this point and so far, they've said like, we haven't really found much telehealth fraud. If anything, has been more telemarketing fraud. A couple of other things to be aware of. So underneath the No Surprises Act, there are certain things in there that may sort of impact the use of telehealth or how hospitals or clinics set up telehealth. So there are certain notifications or balanced billing prohibitions that might touch upon telehealth, such as, for example, if you have an out-of-network telehealth provider that furnishes service to a patient in-network or provider furnished services to an uninsured or self-pay patient, you may need to provide some of those notifications or it may be prohibited. So it's just something to like be aware of that you might want to look into. And then there were proposed regulations for 2023 on health plans and ACA that required plans to submit information on services being offered via telehealth. It's not counting the network adequacy. It's more sort of like, we want information so we can study this a little bit further. So just be aware of that as well. And then interestingly, towards the end of last year, there was an executive order that President Biden signed, and there was something on HIPAA in that 2 things. The Secretary of Labor shall update existing rules and policies consistent with applicable law and to the extent practical to allow individuals entitled to medical treatment under their workers' comp to conduct routine medical treatments through telehealth. So that has always been an issue of like, for workers' comp, how does telehealth work in there? So that was passed, or that was signed into an executive order. And also in that executive order directed Secretary of HHS to develop guidance for entities regulated pursuant to HIPAA on providing telehealth in compliance with HIPAA rules to improve patient experience and convenience. So right now, HIPAA does not really have anything telehealth specific within it. It's because it just hasn't been updated in a while. So this is sort of like the first step where we're seeing sort of like possible changes to HIPAA that may result in a telehealth specific policy. So that's something else to keep an eye on during this year. I don't know if it's going to happen this year. It was an executive order, so it may happen this year, it may happen next year, but it's something definitely that CCHP will be keeping their eye on just to see what develops. States, what's going on the state level as well. So as far as Medicaid programs, their permanent policies and fee-for-services, all the states in DC are reimbursing for some live video, maybe like very narrow, maybe pretty broad. Store and forward remote patient monitoring, not as popular, but they've made gains over like the years. More interestingly is audio only. We're seeing that appear more and more frequently in states. It's like reimbursing for some type of audio only, usually a lot of caveats on it. It's sort of just saying like, it's only for mental health services or audio only in these types of situations, but definitely a change from what we had pre-pandemic. Pre-pandemic, really, it wasn't considered underneath telehealth. It really wasn't something that we saw policies to reimburse for, but we're seeing more and more of that being adopted as permanent policies in the state Medicaid programs. Private payers. So again, this is like being another shift. So 43 states in DC have some type of private payer law. And usually a lot of the laws, when you were talking before the pandemic, they ranged from laws that said health plans, you can reimburse for telehealth delivered services if you want to, all the way to health plans, you shall reimburse for telehealth delivered services, same way you would have in person, and you will pay the provider the same amount. And there were actually fewer states on there mandating that parity and payment side of things. But now we're starting to see like a lot more states being very explicit about that in their commercial payer laws. So we've seen more of that crop up here. So that's also been a change as a result of the pandemic on commercial payers and like the state policies around them. So what we had in 2021, we had 47 states pass 201 bills related to telehealth. And the most popular issues were around private payer reimbursement, Medicaid reimbursement, and cross-state licensing. We get a lot of questions about cross-state licensure. So that's definitely like a topic that a lot of folks are interested in. And then policies impacting specific professions also were sort of popular and showed up a lot. Online prescribing and specific language that telehealth was allowed for certain providers. Before the pandemic, either it was just limited to like a specific group of providers, such as like doctors, nurses, and maybe did not really say anything about other types of providers, such as your allied health professionals, or explicitly excluded them. Now we're seeing more inclusion of the different types of healthcare providers who can use telehealth, very explicitly can use telehealth to provide services. Some of the examples of what we saw in 2021, the big one is like that top one, temporary extension of COVID-19 waivers. So as I said earlier at the beginning, we've seen some states starting to adopt permanent policies. We've also seen some states, I call it kick the can down the road, sort of like strategy of where they will put a date out into the future and say like, we'll leave these policies in place until, the end of 2023 or something like that. So California said that they would like leave things intact, the temporary policies, until the end of 2022. Connecticut, I think, is 2023. And other states have done that as well. Licensure changes, we saw Arizona and Florida not require a full state license for their state, but they will require some sort of registration on their registry on there. So that's also been a change from what we had been seeing before the pandemic, where usually the licensure issue was either dealt with like you got a license in state, or maybe the state was a compact member, belonged to a compact, and then that was like another way of addressing it. Now we're seeing at least 2 states that said, we're just going to create this registry. You go through this process and you get on this registry, you don't need to get a license in our state, you can provide services. So that's something like that was different that we saw emerging too from the pandemic. I mentioned private payer laws that, we've seen more that will require parity of payment, but also really like an interest of prohibiting insurers from contracting with just one telehealth company, just saying like, we will meet our obligation underneath these commercial payer laws by like engaging with a company. Specific laws saying like, no, you must allow your in-network providers to be able to use telehealth and get reimbursed from them and not have them join like this telehealth company in order to do that. So things like that, I think it's appearing because concerns around continuity of care of like using an outside telehealth company. Audio only payment, as I mentioned earlier, again, becoming popular, gaining more traction in states of like keeping that around. And that's a lot of times that's in reaction to understanding that not everybody's going to have to be able to access live video because maybe they don't have broadband capability for whatever reason. So that may be the only way some people can receive services is through audio only telephone. And then the end of the PHEs. So on the states, it was sort of a mixed bag because depending on how they set their telehealth policies, did they connect the expiration with it to a specific date or to a state declaration of a state of emergency or to the federal one? And it was a little bit like all over the place on what exactly states did. And some states, did multiple things. They had like a specific expiration date, or they tied it to a state emergency, or they tied it to public health emergency. So depending on that, that can mean that what state you're interested in may have already had their policies expired because it was either tied to like a specific deadline or the state had declared their public health emergency over. So be aware of that too. And that's about it. That's sort of your quick sort of roundup of like what is happened, what's going on, our current state of 2022. What we have to look forward to is probably a little bit more solidification on what some of the permanent policies are going forward, both on the state and federal level. It's really going to depend on like the PHE, a lot of like when the federal public health emergency is declared over. With the Omicron here, it's kind of hard to tell. At least definitely we know the PHE has been extended for another 3 months. So it's quite possible that could be extended again for like a couple or more months, and these temporary policies stay in place. Somebody did say to me that with like sort of the extension of the public health emergency, there may be a feeling of like less urgency of making a decision on permanent policies. But then we don't know when the public health emergency might actually finally go away. I don't think it's going to go away. At least definitely we know it's for 3 months, but maybe over the next couple of months, just because of the Omicron surge that we have now. They may feel if we declare it over too soon and maybe a little bit premature. So it's probably likely going to get renewed at least one more time, I think, and then we'll see where we go from there on the policies. But it is still a never-changing landscape. I hope this has been useful to you. And these are CCHP's contact information, like our website and our newsletter that you can subscribe to. But we also have like our info box that you can send us specific questions on. But right now, I'm going to go ahead and take questions from the audience. I see we have some in the Q&A. So let me just take a peek in there and see what people are asking. All right. Is there a modifier 93 for audio only? Okay, so the AMA recently came out with a modifier for audio only. So that's probably going to like go into effect. Pretty much CMS is probably going to tell folks to start using that. I can't quite remember exactly what the number is, but they did come up, AMA did come up with a modifier. And I would guess that CMS would say for Medicare, like start using this modifier for showing audio only as well too. They haven't come out with the policy of saying like use that modifier yet, but usually when AMA comes out with like their codes and their modifiers, CMS says use that one. So Molly Jones, post PHE, will FQHCs have distance site restrictions for telehealth services, which I guess is, at this point is just a behavioral health visit. So Molly, again, if we're talking about post-pandemic, post-PHE, FQHCs, at least in Medicare. So Medicaid's a different story. It's going to depend on what state you're in. When we're talking about Medicare, FQHCs cannot be distance site providers for telehealth services. Again, what they did with their policy was redefine a mental health visit where you can use live video and audio only to provide the services. So that's not telehealth. So the whole thing of them, are they a distance site provider, that type of thing, that doesn't apply because it's not telehealth. So it is an FQHC providing a mental health visit. It's very confusing. I do understand that, but that is like the way that policy works. It is not an FQHC providing services via telehealth. It is an FQHC simply providing a mental health visit. And they just happen to be using live video or audio only. Since CTBS, Maria, since CTBS is not telehealth, does it mean it's not subject to licensure restriction? No, it does not mean that. It is not considered telehealth, but you still run into those licensure issues depending on like where you're providing services to. And keep in mind also, licensure is underneath like state control. So it's gonna, you'll have like a different situation depending on what state you're in. For the most part, basically states are saying you need to get licensed, but it still applies. So CTBS doesn't mean that you get a pass on licensure. Can you take some time to break down what is available for use of audio only telemed that is non-behavioral health, and how do we designate it in the chart? Is it reimbursable? So right now, underneath the public health emergency, if you go to, if anybody has the link, there is a link on CMS's website, a telehealth eligible services, and it lists all the services on like the COVID list, and it lists on there like sort of what's on the permanent list, what's on the temporary list, and what's allowed via audio only. So that is probably the list that you're looking for. And there are some services there that are non-behavioral health. So I would say go to that list. I can like search for it now, but I need to answer these questions. If you want to like email CCHP afterwards, then we can provide you with that link. Does every state follow federal definition of telehealth? There is actually not one specific definition of telehealth on the federal level. And the answer is no. States a lot of times have their own definition of telehealth. Sometimes it is embedded in their state laws. So they have a specific definition. Sometimes it is, if you're talking about the Medicaid program, they may have their own definition to it. So it is going to vary from jurisdiction to jurisdiction. Can we find the category 3 telemedicine service list? Yes, again, I believe that's on CMS's website as well too. What are you seeing for cross-state telemedicine? Still okay while in PHE, or it depends on payer states, etc.? Yeah, it's going to depend on, I'm going to assume when you say cross-state telemedicine, like you're talking about the licensure issue, it's going to depend on what state you're talking about, whether it's still underneath the PHE or where they allowed it. Because again, I said some states have expiration dates on like their temporary waivers. And then if it is expired, what their permanent policies are. So it really does depend on what the state is. To clarify, if a service was moved into category 3, it will be reimbursable through the end of 2023, even if PHE ends. Yes. So if it was moved into category 3, it sticks around until 2023, unless CMS changes something again with this year's physician fee schedule. But right now, it's just sticking around until 2023. But some other services are still only on the PHE list and were not put into category 3. Yes. So there are some services that are still on the PHE list. They will disappear unless they are suddenly moved over to category 3 or put on the permanent list. But right now, as of today, if the public health emergency was declared over today, those services not in category 3 or not on the permanent list, they go away. They are no longer going to be reimbursable if you use telehealth to provide that service. And unless moved to category issues will not be, yeah, okay, so answered that one. Courtney, do we have insights as to how or what tracking CMS is requiring for mental health services? Not at this point. Hopefully, again, they will come out with some further guidance. Again, I think probably because we're underneath the public health emergency, they're just taking a little bit more time to do that. But right now, nothing, no clarification on that. Sorry, Courtney. In the past, you mentioned that the Biden administration may pull back on telehealth once pandemic exemptions or waivers are expired. Do you see any evidence to change your future forecast, or is it the same for you now? You know, there's a new administrator for HHS, and I don't really know her. I was on a sort of a CMS leadership overview session that they did. Telehealth was mentioned. There wasn't really sort of like a definitive answer. They just said like, we're still examining it and going to, you know, work on it basically. I don't know. I simply don't know exactly where they may be going with this. I mean, part of it is not really left to the administration. A lot of those telehealth limitations, as I mentioned earlier, are embedded in federal statute. So we really require Congress to act on that. So there is only actually so much that the administration can do without Congress acting. And we've seen how difficult it might be sometimes to get things through Congress. So I don't know what will happen. how much the administration will do or can do, just simply because a lot of those major barriers to telehealth as far as permanent policies are going to require Congress to act. Does the mental health services in Medicare policy include SUD services? Okay, so SUD is like kind of a little bit of a different beast here. I did not go over this because I was trying to keep the water as clear as possible. So even before all those policies that I mentioned earlier, in permanent Medicare policy around telehealth, there was an exception for SUD. So this was done back in 2018 or 19 was when they passed the policy. And this was actually a statutory change. So this is like permanent policy and Congress did this. So basically what they said was they allow telehealth services to treat substance use disorder and co-occurring mental health disorders to take place in the home and without the geographic limitation. So that was an exception that was already in there. It actually predated the pandemic. So your whole question about, well, then do I need to do like an in-person visit every 6? No, because this was already something that was like existed. And that was like a statutory change before this whole 6-month visit thing came into place there. And really, again, the 6-month visit and 12-month follow-up visit, why in-person visit, why that is there and why when you have to meet that, that's only if you are trying to do those mental health visits in the home and without the geographic restriction, and you don't fit into any of the exceptions that existed before the Consolidated Appropriation Act. Again, I know this is very complicated. It's sort of like, it's this policy except in this case, and then it's this policy except in this case. So it is like very nuanced. So for substance use disorder services, there was already an allowance to let that take place in the home and without the geographic limitation taking place. And that's going to still stand. And also there was, if you had that treatment going on and you had a co-occurring mental health condition, you could still also do that. And you didn't need that 6 months in person because that already existed before this new policy was in place. So it's like, basically it's old policy. If you meet old policy, you don't need to do like that 6-month in-person visit. Again, CCHP has a fact sheet on our website. We try to break it down as clear as possible, but it is very nuanced. I do understand, and I understand why there's so much confusion. And hopefully I did not confuse you even more with that answer. If a patient goes to an eligible originating site that's in an urban area for a telemedicine visit, do the CAA person visit requirement apply? Yes, because again, you are trying to avoid essentially that the existing, what I kind of label it original telehealth Medicare policy. You're trying to like get an exception from that, and one of the exception is the geographic limitation there. So yeah, it's geographic limitation. I think it would still apply even though they're in a clinic setting because you're trying to avoid the geographic limitation. So that would probably still kick in. If FQHC has primary services and behavioral health services, can the in-person visit with the same organization be done by a family practice vendor versus a behavioral health provider? I don't think it can, because I think it is that it needs to be with the provider who is providing that telehealth service there. So it would need to be with the behavioral health provider. But keep in mind though, if they are in like the clinic setting, they don't need to meet that in-person requirement. So if they've come in for like their primary care visit, and then you connect them with their behavioral health specialist via telehealth, and they're still in that clinic setting, that in-person visit's not going to kick in. The only in-person visit, the in-person visit for FQHCs and RHCs only kicks in if they're receiving services in the home. Are audio-only non-mental health services on the Category 3 list or on the COVID list? So it's not only audio-only services. So audio-only is a modality. So it's not an audio-only service. It's a modality. So basically, Category 3 talks about the service that is covered. So not the modality that's being used. And the modality post-PHE audio only can only be used for mental health services. So there's a distinction there, is that the service is on there, but the modality is not connected with the service. It's just saying like that service can be provided via modality. So it's two different things. For telemental health into home, will they need to document actual location of the patient for billing purposes, or can it just be patients located at the home? Again, I don't have any clarifying policy on how they want this documentation to take place. So I can't answer that. And I don't have anything. See, as far as I know, CMS has not issued clarifying instructions on that yet. Does mental health provisions referred to in relation to Medicare also apply for Medicaid? No. So Medicaid policy is going to vary from state to state and what they decide on what they're going to do. Some may adopt something very similar to what Medicare is doing, but not all states. So you're going to have to just figure, you can go to CCHP's website to see what their Medicaid program is doing, but it is going to vary from Medicaid program to Medicaid program. Does this mental health in-person 6-month rule start now? So no, it starts when the public health emergency is declared over. So it's not kicking in just yet. What about FQHCs look-alike? Mental health visits are not considered telehealth. They didn't say anything about look-alikes on like whether they would apply to it. They just said fairly qualified health centers and rural health centers. If FQHCs are providing a mental health visit via telecommunications technology, but their patient is coming into clinic, use telehealth kiosks to access service, is that allowable? Okay, but their patient is coming in. Well, this means that's so again, if the patient is within the clinic setting, the 6-month, 12-month visit does not kick in. It is only when they are receiving services in the home. Should we use you as an example as mental health because you have the same narrative? I'm not sure I understand that question. I mean, if you want to clarify, I'm sorry, I don't understand that one. So modifier 93 is only for mental health service. Everyone has to bill telemedicine, not audio. Again, I'm not quite sure I understand that question. Sorry there. If you want to like maybe clarify a bit more, then I can see it when I get further down. What blurb is required in all types of providers stating that the visit was done via telehealth? This is the time, length of visit. I don't have any specific language, so it's not necessarily a blurb. I believe there is like coding that you do, a modifier that signifies that the service is done via telehealth. Will FQHCs be able to provide medical services via video and audio only, not behavioral health services, medical services? No. So that's not what the exception is. It is the redefinition of a mental health visit. So that does not mean that they are able to use telehealth to provide those services if they want to get reimbursed by Medicare. I'm not saying that it's illegal for them to do that, but they just will not get reimbursed by the Medicare program. For originating site fee, should we be billing for the visit and this originating site fee of the no, if the provider is at home and the patient is at the clinic. I believe they can if the patient is at the clinic. It's really more the patient using the facility that you can bill the originating site fee. Has there been any progress in coverage and reimbursement for route physical monitoring for less than 16 days? 16 days requires. I've not heard anything on remote physiological monitoring for less than 16 days. Only remove the 16 for COVID or suspected COVID, not those with chronic diseases. I haven't heard any new news on that, to be quite honest. Does New Jersey reimburse for audio? I can't remember that offhand. You can check out the CCHP website. We do, again, as I said, we follow the Medicaid policies, so you can check there. I missed the name of the bill passed in December 2020 that requires a 6-month in-person visit Medicare patient. Is the Consolidated Appropriations Act. So CAA is the acronym for it. Again, the bill that was passed in December 2020 that did the whole 6-month in-person visit thing, Consolidated Appropriations Act. The diabetes prevention program might benefit from telehealth and remote monitoring. Can the medical portion also be included? depends on what code you're talking about. So there's like a cluster of codes. There's chronic care management, there's remote physiological monitoring, remote therapeutic monitoring. If you can be a little bit more specific on like which ones you're looking at. They have specific definitions on like their services there. So you can like look at those to see if it applies to the situation that you want. Cross-state, if provider in New Jersey are not credentialed in other states, are they not supposed to see those patients? Or are we only allowed to see patients in New Jersey or their registration in these areas? Do you mean licensed? If they're not licensed in New York or Pennsylvania? If they're not licensed in New York and Pennsylvania, you have to check New York and Pennsylvania to see like what their requirements are for licensure. I'm not sure what you mean by credentialed. So I think you probably meant licensure and not credentialing. We found Arizona telehealth out-of-state licensure application appears that this is for MD only. Do you know if there are other applications for DO and other providers? I don't think they did it for other providers. I think they only did it for physicians. What is the best place website to get state-specific telehealth updates and notices are up to date? Probably CCHP's website. It's cchpca.org. It's also on the slide, I believe. Hold on. Yeah, it's on the slide as well. Sorry, the Q&A for me was blocking that. Would the presenter consider repeating the information pertaining to states that declare the PHE over in their state? She spoke quickly. I'm not sure I understood all of that. So what I'm saying is that some states, their temporary telehealth policies have expired because they had an actual expiration date to them. They declared that their state of emergency was over or that their waivers had expired. So you need to check your state to see like if those policies are still in effect because it's different for each state. They've had different approaches to it. I think that's what you wanted me to cover. Is the Medicare 20 waived for telehealth and remote patient monitoring? So copays, I don't believe are waived. So it's basically, if you have a copay for that service, you're still going to have to pay it regardless of like what the way the service was delivered in, whether in person or telehealth. So difference between category 1 and category 2 tests. So again, this is the CMS's way of deciding on whether to put services on a permanent list. On the permanent telehealth list, they can pass a category 1 test or they can pass a category 2 test. A category 1 test is the service that's being proposed to be put on the permanent telehealth is similar to a service that currently exists on the permanent telehealth list. If it does, it passes category 1. Category 2 is, does the service that you're proposing have enough evidence around it on to show that it can be provided via telehealth, and the efficacy of it being provided via telehealth is like good. Is it as good as like in person, that type of thing? So category 2 test is a little bit harder to pass. So where you usually see services being put on the permanent list is because they passed a category 1 test. So that's the difference on what those two are. In terms of Medicaid telehealth, have many states moved to make PHE flexible for beyond the PHE, and do you think more states will move in that direction? I haven't done an analysis on like what it is, but if I were to guess, it's probably about half and half of like policy has been made permanent. Sort of the biggest area, I think, in where we've seen Medicaid policies adopt things is like they've expanded their telehealth policies as far as like what's allowed. And then we, as I mentioned in my presentation, we've actually seen more audio only be allowed too as well. Will they continue to move in that direction? I think it's going to be a mixed bag across the country, to be quite honest. For FQHCs, is there a remote patient monitoring code? If not, when is that expected? So for those communications technology-based services, FQHCs and RHCs can provide some of those services, not all of them, but there are allowances for some of those services for FQHCs and RHCs to provide. And you can, so CMS has some learning network booklets on those as well, where they like signify what those are. I can't remember them off the top of my head, but there are some remote patient monitoring codes, some of those codes, not all of them, that FQHCs and RHCs can provide. Regarding RTM, can medication therapy be involved if severe asthma is incorporated and the inhaler is? Yeah, that question I don't know the answer to, so I apologize to Anonymous here. Regarding RTM, can medication therapy be involved if severe asthma is incorporated and the inhaler is? I IoT enabled. I don't really know the answer to, so my apologies on that. We are actually over on time, but I only have about 10 questions left. So I'm going to stick around and answer the rest of these questions here. But if people need to drop off, this is being recorded, so you can check on this later. Back to cross-state telemedicine offerings inside of the PHE. If the patient is on Medicare, can they do cross-state telemedicine because we are in the federal PHE? Again, I think I understand the question. Again, licensure is a state issue. So even if they're a Medicare patient, they still have to follow the state laws on like licensure. So it's going to be dependent on like what state the patient is located in, because when you're talking about the licensure laws on delivering services, where the patient location is. So depending on where the patient location is in that state and what their policies are around licensure. So it doesn't matter if they're like a Medicare, Medicaid patient or commercial payer. It's going to be like the licensure law of the state the patient's located in. Can you provide a link for the overview of what is and is not in category 3? That would require me to search for it. So if you would just contact CCHP afterwards, we can do that. But I'm sure people don't want to watch me trying to like search for that right now. If we get on registry to provide services in Florida, do we need first have to see if the patient we are licensed in would allow that? I'm not sure. That's probably a question for your licensure board to see if like there's any prohibition on that. I think probably the requirement, at least on Florida and Arizona, and I'm not sure 100%, I haven't like looked at the requirements, would probably be something like you need to be in good standing with where the state that you are licensed in. So that's probably a question more for your medical board to see if like they would require anything of you if you did get on these registries in other states. Let's repeat there. Do you anticipate the 98 modifier code to be required for Medicaid and private payer state laws and documentation? It's going to depend on the Medicaid program and the commercial payers. So I do know that that can get confusing for folks because it's like different payers require different billing requirements. So I don't have like a definitive answer for you. It's going to depend on what they're going to say. Is the requirement 6 months, 12 months in-person follow-up visit to the STAR video or prior 6 month poster in person? It's 6 months, 12 months prior to services being delivered via telehealth. So if you had an in-person visit with the patient 7 months, and then 7 months later you start services via telehealth, that doesn't count. It's got to be within that 6 month visit or 6 months before you start providing services via telehealth. Do you have any guidance on the new modifiers FQ and farm the use of place of service to? No, sorry, I don't. Kendra, and Kendra, if you want to email me afterwards, I'm not quite sure I understand your question. So if you want to email me afterwards and with more explanation, I can like take a look at your question then. Any provisions for telehealth delivered in the school setting? Not on the federal level, but check on the state level. States have been a little bit more open about school settings. Cross-state, New Jersey. Okay, that's a repeat of that. Yes, not licensed. I'm not sure what that refers to. I'm sorry. Telepolicy is so complex between Medicare, Medicaid, and commercial payers. Administrative burden, clinic stays tracking this is in South of barrier telehealth. Are there viable means to clinics to elevate this challenge to policymakers? So yes, one thing is you can always talk to your policymakers about this. They actually probably prefer to hear more from actual clinicians and actual patients more than from me of saying like, these are the hardships that you face. And the last question is, besides RMT codes, fraud and abuse and behavioral health, how can we help you move telehealth forward for society? Thank you and be well. Thank you, Alan. Really, the thing that you can do is, as I mentioned earlier, is talk to your policymakers, both on the state and the federal level. Again, they really do like to hear more from patients and providers, like people actually receiving services and people actually providing the services rather than, you know, from me, who's like this policy person. They hear from me all the time. They want to hear the actual stories from folks. So I would say like contact both your congressional members and contact both your congressional and your state legislative members as well too, because they really do want to hear those stories. Those are the things that like have the most impact on them. So that's what I would recommend. All right, then. That's it for the questions. Thank you so much. Thank you for having me. Thank you for sticking around. To the folks who did stick around. Aria, I'll give it back to you to wrap up.
Thank you, May. Just a reminder for our next webinar on February 17th, it will be hosted by the Telehealth Technology Assessment Resource Center. It will focus on their pandemic response action plan. Registration information is listed on the NCTRC website on the events page. Next slide, please. We do value your opinion and ask that you take just a few short minutes and complete the online survey that will pop up at the conclusion of this webinar. Thank you again to Mei Kwong for presenting today and to the Center for Connected Health Policy for hosting today's webinar. Have a great day, everyone.